Hello, everyone, and thank you for joining us. My name is Jennifer Larson, and I am the training coordinator for the Office of Community Living. And we are starting off with this presentation today. We ask that you do use the chat to type in your questions as you have them, and our team will be working to answer those as we go along. You can get a copy of today's slides. They are available for you on our ARPA webinars webpage, which will add a link to the chat or in the chat for you so that you can click on that and grab the slides. If you are listening by phone, you can press *6 to unmute your line or press *9 to raise your hand, and you can participate that way. We are using closed captioning as well during the presentation, so you can either turn that on or off using your icon at the bottom of your screen. And with that, I will turn it over to Haley Gleason to start our presentation.
Thank you so much, Jen. You can go to the next slide. I want to welcome everybody. Thank you so much for being here this afternoon for our ARPA HCBS webinar. This is our first webinar of the year, so we are so excited to get kicked off and welcome you all to the conversation. So we've got quite a packed agenda today, as we usually do. So we will open up by sharing a couple of general ARPA updates. And then we have a couple of guest speakers we are so excited have joined us. They will be talking about the Capable program, which is one of our many ARPA HCBS initiatives. And then we'll move on to talking a little bit about grant updates. We have several grants that are well on their way, and we wanted to provide some updates there. We also have some grants that are currently open. Their requests for application are live now, so we wanted to make you aware of those in the event that those might be a good fit for your organization. And then we will close with just a couple of other general updates, some focused on the Office of Community Living and one on the PHE. Next slide, please. All right, so we'll kick it off first by sharing a couple of general ARPA HCBS updates. Next slide. First, we wanted to provide an overview of our spending status. I'm sure many of you are curious where we are in terms of our spending to date. So just as a reminder, our ARPA HCBS timeframe runs through December of 2024. So we've got a little less than 2 years left to spend all of the money. I did want to point you to a bit of a change in our overall budget. Due to identifying some additional savings, our budget has increased by a bit. Our overall budget is now $552 million. And as you can see, these numbers are through January. So we have spent approximately $100 million and then have another $214 million that is either encumbered or allocated. So you can see the breakdown there by either rate increases or through our other projects and what we spent to date versus what's allocated. So we are well on our way to spending that money, but we do have still a ways to go over the next 2 years. Next slide, please. And next, I'm going to hand it over to Colin Laughlin, who is going to provide a couple of updates and changes to some of our projects. Colin, are you on? I am not hearing him. So I will just go ahead and cover this. So this is a new project. So if you all remember, we had 63 ARPA HCBS initiatives, and we're excited to announce that we have one additional project that has been added. So this project is called the Community Transitions Support Project, and we have 5.9 million that's dedicated to this work, and it's really to support our initiatives to address the Department of Justice findings related to community transitions and the nursing facility diversion process. So these, you can see, it's going to fund a number of different efforts, and there's more details in our most recent quarterly report that was submitted to the Joint Budget Committee if you want to find out more. All right, next slide. Great. And then in addition to that, we also have some funding that is going for some additional rate increases. So that also was outlined in our most recent quarterly report that was submitted to the Joint Budget Committee on February 1st. But we wanted to give you a little bit of an overview. It's going to total 34 million. And you can see here some of those rate increases, which include rates for case management agencies, some transportation rates, group residential support services rates, and some funding to support aligning our respite rates across our children's habilitation residential program and our children's extensive services waivers. So some exciting new things that are happening using these ARPA HCBS funds. All right, next slide. And is Amanda on?
I am. Thank you, Haley. So we're very excited. The department has been working on case management redesign for a number of years and will be this spring issuing notice of intent to award for case management agencies as part of case management redesign. But we know that there will be some startup costs associated with the new contracts. And so we have allocated $5.6 million to really support the agencies, including retention payments to keep case managers on board through the transition. You know, we highly value and appreciate all of our case managers across the state, and our hope is to retain each and every one of them through the transition. And so a large percentage of this funding will be part of the retention payments. We were able to earlier this year issue one round, so this will be for some additional rounds, in addition to any of the transition costs that will meet certain criteria that we will set forth and issue through guidance to case managers as part of the transitions that their agency will concur. So more information will come, but we are very excited about this. And then Haley, I'll pass it back to you.
Great, thank you, Amanda. Next slide, please. All right, so we are thrilled to have some guest speakers today to share a little bit about Community Aging in Place, Advancing Better Living for Elders, or the CAPABLE program, which is one of our ARPA initiatives. We will start with Amanda Goodenow, who is going to be sharing a little bit of an overview about the CAPABLE program. Then we will hand it over to Jason McCullough from Brothers Redevelopment, who is one of our pilot sites. And then next, we'll send it over to Colorado Visiting Nurses Association, Colleen Morton, who will also share a bit about their pilot site. So first, Amanda, I will hand it to you.
Hello. Do you have our slides?
Yep, next slide, please. Thanks.
Okay, perfect. Hello. So I'm Amanda Goodenow, and I'm an occupational therapist here in Denver, Colorado. And I have been part of an organization that has been implementing CAPABLE since 2017. I did join the CAPABLE Johns Hopkins School of Nursing team in 2020 to assist with strategic partnership along with the implementation and clinician support. And I now continue to spread the news about CAPABLE through the CAPABLE National Center. So we have partnered with Johns Hopkins to operationalize and scale CAPABLE across the nation in order for more adults across the nation to be impacted by this evidence-based intervention. Next slide. So CAPABLE stands for Community Aging in Place, Advancing Better Living for Elders. It is a client-directed, home-based program designed to increase mobility, function, and capacity to age in place or age in community. It consists of a time-limited services and a series of visits from an occupational therapist, a registered nurse, and a handy worker who work in collaboration with the adult, which is a key component of the approach. The participant is the one driving the goal setting. Capable is an interdisciplinary approach that includes 6 OT visits, 4 nursing visits, and home modifications from a handy person. The program is approximately 4 months long with a limited budget for simple modifications, along with adaptive equipment or durable medical equipment or supplies that is not covered traditionally by insurance. These items are based off of a client's goals and then also to increase their independence and safety and decrease fall risk. The assessments, education, and interventions are all designed to allow and encourage the client to direct the session. The client formulates 3 goals of their choice with the OT and 3 goals of their choice with the RN. 1 goal is then addressed at each visit. The program is truly client-directed. Throughout the program, we are promoting self-efficacy, we are connecting with cultures, we are solving problems and customizing the plan as needed for the client and their goals. Meaning, if throughout the intervention, the client decides they want to work on a different goal, then we're not going to work on the goal they no longer want to work on, and we're going to go on to the thing that they do want to talk about and address. We really do only address the topics that the client wants to work on and learn about. We are also addressing the environment not only for their current needs, but also for future needs through prevention. Next slide. So this is a timeline of what the program looks like within a 4-month period of time. The top row of green, that is the OT visits. The bottom row with the hearts, those are the nursing visits. The OT makes their first visit and completes a capable assessment. The capable OT goes through a series of activities that include functional mobility task, ADL task, and IADL task. They ask them, how difficult are these tasks for you? And the client gives a number. Then they ask, well, how important is it to learn new strategies in order to make those tasks easier? From there, with the items that they identify as important to learn new strategy, the client formulates 3 goals based off of those items. The OT is guiding the client, but not telling the client what to do. On the OT's second visit, a home assessment is completed in order of what the client's goals are. The OT puts together a work order. The first items on the work order are going to address the client's goals. Then the items following those will be the ones that are addressing the client's independence and safety to remain at home. The work order is then sent to the home modification specialist or handy person. From there, the home modification specialist or construction specialist will call the client to set up an assessment day to measure and determine what items can be completed within that set budget. Once the budget is put together from the construction specialist, they are either sending that to the OT or the program administrator to get the okay to order the supplies and then set up the install day. We are hoping that the install occurs between visit 3 and visit 5 of the OT visits. This then allows the occupational therapist an opportunity to practice using the new things that have been installed in the home with the client to ensure safety and independence with this. As you can see, after the OT second visit down below, the RN makes their first visit. The capable RN completes a capable assessment. During this assessment, they're asking questions such as medication management, mood, incontinence, comorbidities, falls, pain, things like that. At the end of each section, the RN is asking, is this something you would like to discuss further? Or do you have interest in this topic? And from those items, the RN picks, or the client, formulates 3 goals with the RN. After the goals are set, the additional visits are spread out approximately every 3 weeks. At one visit, they're working on 1 goal. The visits are spread out over a 3-week period in order to give the client an opportunity to truly practice these new strategies to see if they work for them, to try the new equipment that has been purchased or tools that have been purchased in order to increase their independence or safety with that goal. As we all know, anytime you're trying something new, you're awkward and uncoordinated with it. And so this gives them an opportunity to work on that coordination, but it also gives them an opportunity to work with habituation, which is key for these new strategies. If at the next visit we determine, or the client determines that that strategy that we came up with at the last visit didn't work, then we will formulate a new plan. We'll ditch that strategy and we'll try to come up with a new strategy for that previous goal, and then we'll move on to the next goal. Next slide. So the goal of our program is truly to allow the older adult to stay at home in order to allow them to continue those roles and relationships with their family, friends, and neighbors. We all know once someone moves into a facility, whether it's a nursing home or an assisted living, those roles do diminish. Some of them go away completely and others just aren't as active. Often people feel more isolated once they move away from their home. But through the program, we're also finding that we're able to lower overall healthcare and expenses. So we're able to decrease hospitalizations and emergency room visits through this program. We've also found that people overall feel like they have a increased independence with their ADLs by about 50%. They also have improved depression scores. So we use the PHQ-9 to determine depression scores. And we have an average people increasing their depression scores, or by decreasing, their depression scores by about 65%. So overall, people do feel, one, safer at home, more independent, and their mood has improved, along with allowing them to stay in their roles with their family and care with their families and their neighbors and things like that. The other thing through this program is we are truly trying to teach the person how to brainstorm and strategize. So when a new problem comes up in the future, when the program is over, they do feel more independent and safer. They feel like they can go through that process, so they no longer feel stuck. They can break down the problem and figure out a new way of doing that activity, so it doesn't cause as much pain, or they're not quite as short of breath. Often the strategies that we talk about in one visit can correlate over to multiple activities in their life. Next slide. So if you do have any questions or concerns about the program, just want some more information, you can reach us at capableInfo@capablenationalcenter.org. And we do have a huge team that helps out with both the strategic partnership side, like I do, but also we have implementation specialist, clinical training specialist, and then we're in communication still with Dean Santon out of JHU, who co-developed the program. Next slide.
Thank you so much, Amanda. All right, next we will hand it over to the Colorado Visiting Nurses Association. I believe it's Colleen Morton that will be talking us through what they're working on.
Yes, thank you and welcome. Thank you for having us here, and thank you for the overview, Amanda, because I think that sets the pace for kind of what our programs are. So the Colorado Visiting Nurse Association, many are familiar with. We have several different service lines. We have a home health, a hospice and palliative care, a wellness, and a capable service line. We have been implementing capable in the Denver metro area since 2017. There are about 40 sites across the US and in a couple different countries that are implementing capable. And I happen to know there's many on the horizon that are exploring the opportunity because they recognize the benefits of the program. We are the second state in the United States that are offering capable to Medicaid members. Next slide. These are the areas that we currently are in and have been working since 2017. And some of you may be familiar with the DRCOG footprint of Adams, Arapahoe, Broomfield, Denver, Douglas, and Jefferson County. And then we've been active in Boulder County since 2020. With this pilot program that we are currently working with you on, we are expanding into northern El Paso County and Weld and Larimer County. Next slide, please. So I knew Amanda was going to cover what the program is all about. So what I picked out are some key words to talk about that I think are very important in trying to understand the implementing the program, what the benefits are for everybody, but just to understand it a little better. So evidence-based, that means that there's been research done to support the predicted outcomes. We do have a license that we have with this program, and we have to attest that we are maintaining the fidelity of the program. This is a set program, and that our practitioners are all trained in and before they can take part in it. Client directed, I think that Amanda covered that well. This is a client directed program. Coming from a healthcare background, I am an RN. We go through healthcare telling people what they should be doing, but this is a different model. And the client is directing things that they choose to work on. Some of the qualifications for capable have that they are starting to struggle with their ADLs or IDLs. So having them admit where those struggles are and then having those be their goals allows us to help improve their status and their ability to stay in their home. Motivational interviewing. All of the clinicians, the RNs and the OTs, are trained in motivational interviewing, which are really skills that enhance a client's motivation to change and support self-efficacy. They are using these skills throughout all of the visits in the home with the client. Measurable outcomes. Amanda referred to that there are measurable outcomes. What we do is we do an in-person pre-screen, what we call it, to take some data at the beginning of the program. And then we ask those same questions at the end of the program. And those questions are asked by somebody not directly involved with their care over the last 4 to 5 months. So it's a neutral person. And then we look at what those outcomes are. In my next slide, I'll share with you our outcomes from 2022. And so we had 65 clients that started and completed capable in 2022. So we had more clients than then, but some started in 21. It's a long program, so they weren't done in 22, or some that started in 23 are still ongoing. But ADLs, 75% of our clients showed improvement in their ADLs. 64% showed improvement in their IADLs. Our depression scores improved or had a decline, which that is a positive outcome. 73% of our clients showed movement in that. I think that's really important as we're coming out of COVID years and isolation. And while seniors are able to be out of their homes more, there was still a lot of conditioning and fear out there. So we see that they aren't out of their homes as much. Fall efficacy, 69% of our clients were less fearful of falling. And that one is also a huge one in our senior population. And pain, 20%, 7% of our clients had less pain. Pain is a hard one. Our current funding up to the Medicaid program has been for 60 and older, and a lot of people have chronic pain. So you may not be eliminating their pain, but you're helping them to moderate it. And how can they reduce it so they can do the things that they choose to do or need to do in order to self-care? And if you could go back to the previous slide, please. Independence and safety. I think that that is the bottom line why we do this program, is we're trying to increase independence and increase the safety in their home so they can stay where they choose to live. Fall risk prevention, I showed you our outcomes. This is identified by the National Council on Aging as a fall risk prevention program. Cost savings. There are statistics out there we'd be happy to share if you want to reach out to us that shows the actual cost savings that have come out of the research. But I think it's really obvious that if we think about one ER visit that is prevented by some intervention through the program, that we can enable them to be safer, we've more than paid for the program. And empower. And if you talk to any of my staff, they know that empower is like my favorite word with this program, because what we are doing is empowering the individuals to help self-care better, to stay in their home, be kind of in control of what's going on for them. As Amanda referenced, they teach them problem-solving skills so that when we are no longer in the home, they are able to look at a problem, break it down into smaller pieces, and figure out how to become unstuck and to move through that to do what they want to do. If I could go 2 slides ahead, please. Thank you. So process for referring potential clients. Our email, we have a dedicated email. It's capable@vnacolorado.org. We also have a dedicated phone line of 303-698-6302 or a fax line. What we need is a potential client's name and a phone number minimum in order for somebody to be referred into the program. If you have additional demographic information, that's helpful. Individuals can self-refer. We have a lot of people calling us directly because they're interested in finding out more. Our first call to a potential client is informational to explain the program and see if the individual meets the qualifying criteria for the Capable program. I always like to reassure people that they are not committed to anything. This is just more to explain what's available to them. If they do qualify and are interested and seem a good fit, then the next step is an occupational therapist would call them to set up their first in-person pre-screen visit. At this time, the Medicaid funding that we have for a pilot program is for anybody 18 and up that has a Health First membership. They do have to qualify for the Capable program by having a deficit in one ADL or 2 IADLs that they self-admit to. But from the Medicaid standpoint, we just need to confirm that they are a Health First member. I think that's it.
Thank you so much, Colleen. Appreciate you sharing about your program. And I know you all are a wealth of information since you've been doing this for several years. So you've been a great partner.
Great.
Next up, I'd like to welcome Jason from Brothers Redevelopment. Talk about their pilot.
Hi, thanks, Haley. Appreciate it. My name is Jason McCullough. I'm the director for home modification and repair programs at Brothers Redevelopment, and I'll be going over kind of Brothers real quickly and then into a pilot program we're starting right now with Capable. So this program is a partnership between Brothers, Johns Hopkins School of Nursing, the Capable program, and the state of Colorado, specifically with the Department of Healthcare Policy and Financing. Next slide. So Brothers Redevelopment is a housing-focused nonprofit. We're about 52 years old. We work in anything housing in Colorado, and we have a lot of different departments that handle the various needs folks have related to affordable, accessible, and housing sustainability and retention. And I won't go through everything here for time, but we do just about everything from developing housing to managing affordable housing, to providing rental assistance, housing placement, counseling, rehab, and even a volunteer department that paints about 100 homes a year. Next slide. Here's some outcomes from this last year. So I won't go through all the numbers, but overall we helped we served about 30,000 people in Colorado for about almost $4 million in savings for disabled and older adults. And then also we provided rent, mortgage, and utility assistance to the tune of 8.6 million. A lot of housing, and then we also broke ground and are working on a 72-unit long-term housing facility on East Colfax called Valor on the Facts. That's in partnership with the Traumatic Brain Injury Alliance, and that's the first of its kind in the country. So we're very excited for that to get finished up this spring. Next slide. Also, we are used to, and we work with a lot of ARPA and HUD funding. So we're familiar with a lot of different funding sources, but wanted to make sure we mentioned that in 22, we did quite a bit with ARPA and quite a bit with HUD. Most of my programs in home rehab are through HUD and the community development block grants. So the structure of Capable is not completely alien to us. Next. And so my department, home modification repair, or HMR, we work mainly if you're along the I-25 corridor in Colorado, we probably have some way of assisting you if you're an adult homeowner in need with a disability or a low income. We work pretty much everywhere, north to south, obviously the Denver area, and then we have programs in El Paso County. And this, the capable pilot just adds to that. It'll also allow us to head into more mountainous areas and park and teller. And I'll get into that in a moment, but a lot of stuff going on in with home repair and rehab and accessibility work. Next slide. So our specific outcomes last year we focused on service safety and compliance, obviously. We just have some photos for some projects there. We completed 375 projects last year. We successfully executed service requests in the number of 515. So that's within those completed projects, how many service requests were there related to home rehab, deferred maintenance, home safety, and accessibility. And then the total savings to clients with my department was about 1.8. So we almost hit 2 million in savings to clients, but we're working on that for this year. Our projects ranged, I call it the archipelago of service. They range from $1,800 to $20,000 per project. That's per household. And that really depends on where you live, what your need is, what's your home ownership status, what's your age, and what's your income. So depending on where you're at and all those other qualifications tells me what we can do for you with the various programs we administer. Next slide. So our key capable objectives for this program starting this year is to implement capable program for Health First Colorado member populations in Southern Colorado Springs, as well as outside of the city limits in El Paso. And then we're also hoping to reach people in Park and Teller counties without compromising the quality of service. So those are a little more remote. You're crossing the Continental Divide, you're heading into more rural and mountainous areas. But we know there's still folks with needs there, and we're using our contacts and the various partners we have in the area to access folks in those areas. Two is to evaluate evidence. This is a big one for us. As you can see, my outcomes are all based around number of and dollars saved and services offered, but we're looking for actual evidence-based data that drive our programming. We're hoping to use this capable model and those measurable outcomes to be able to apply that to our other programming. And then also, we obviously wanted to create healthy and safe home environments. That's a big one for us. That's part of our mission. And then we want to create program sustainability. So when we bring a program on, we want to lift it up and make it applicable wherever we can and keep it in-house. Next slide. Our overall goal for Capable is to use the data collected through Capable implementation to better understand how we access and use our home modifications to improve health and well-being for older adults by supporting two things: their ability to age in place, and if they have issues with aging in place, to help them live in community. Those are two big terms you'll hear a lot from our side of the aisle. Because we feel that we know that folks that are able to stay in their homes and be confident and comfortable in their homes live longer, and they're more lowers isolation, lowers fall risk, all those terms that Colleen had. That's a big part of our mission, and it's we believe that what we're doing helps people stay alive longer and happier and more comfortable. So we're hoping for those measurable outcomes to kind of help us with that. Next slide. And finally, the recent progress we have for this program. In October of 22, we became licensed, which was a fairly, I will say this: Capable has everything. Once you get in their lane, they take care of you. If questions are answered, there's someone to refer to. It's a very delineated and clearly administered program. So, which is a wonderful change for us. December of 22, we partnered with an OT firm or OT company and nurses, and they finished their Capable certification as well. So everybody is certified. We're all background checked. Everybody's kind of ready to roll at the end of this last year. In January, this far, we had our first OT visit in January. We've had about 10 invited. We're processing through and starting arranging scheduling visits for about 4 of those. So for our goals, we're on track to complete successfully the program that we signed up for this year, but we're hoping to be able to report back and really work with Capable and the state to find ways to keep this program going in the future. Our referrals are coming from Colorado Housing Connects, which is our statewide call center, the Resource Exchange, and the Pikes Peak AAA. I think that's everything for me. I tried to keep mine short and sweet. So if there's any questions, otherwise we can turn it on to the next presentation.
Great, thank you so much. Thank you to Amanda, Colleen, and Jason for joining us today and sharing a little bit about your program. We are grateful to have such wonderful partners to be pilot testing this program. And as many said, we are excited to see the evaluation data, though I have to say, I think as Amanda mentioned, and Colleen, that there's already a lot of really wonderful data to show the impact and evidence of this program. So we're just hoping to add to that and show that it is also effective here in Colorado. So thank you so much. And next slide, we will open it up for questions. So if anyone has any questions about the Capable program, or you would like to direct them, to Amanda, Colleen, or Jason, you can do so now. You can either raise your hand, you go under reactions below and hit the raise hand button. Or if you're on the phone, you can press *6 to unmute yourself. I will pause for a minute and see if anyone has any questions for our speakers. All right. Don't see any hands raised, so not hearing anything. I'll keep us moving. Thank you again for joining us. All right. So now we're going to move on to talking a little bit more about our grant programs. We'll talk both about some of our recently awarded grants and the grants that are currently open and available if you're interested in applying. To start, if you want to go to the next slide, we wanted to highlight one grant program in particular, 2.01, our behavioral health transition support grants, which have recently been awarded. I'd like to welcome Jay Jackson. She's our behavioral health grant policy specialist, and she's going to talk a little bit more about this program.
Hi, good afternoon, everyone. Yes, thank you, Haley. I will jump right in. As Haley said, I am the grant specialist on the Behavioral Health Initiatives and Coverages team. And the primary grant I work on is the ARPA 2.01 Behavioral Health Transition Support Grant. So this grant will provide funding for behavioral health crisis and transition services to support a higher acuity members who are moving from an institution, a hospital, or corrections to the community. It's specifically focused on increasing capacity for community-based care. The grant was open to local communities, including providers, non-governmental organizations, counties, and others to implement programs that are specific to their behavioral health capacity needs and their geographic area. So the grant total was $14 million. That's how much we had to award to the grantees. The grant was open for 30 days in October 17th to November 16th. The applications were reviewed by a team of subject matter experts and reviewers, and they selected 9 of the 14 individuals or organizations who applied. The applicants were notified right before Christmas, so that was a nice little Christmas surprise for them, and contracts began this Monday, February 13th, 2023. This grant did receive the extension, so it will end on December 31st, 2024. That's kind of the overview of the grant, its goal, and the application timeline progression. Next slide, please. And I speak really fast. It's something I haven't been able to shake, so if you need me to slow down or go back, just let me know. I want to get into the 9 grantees that we selected. They span the state, which is really great so that we can get these services into some of our harder to reach areas. And they were selected to provide services in rural, urban areas to at-risk adults, youth, and justice-involved populations. Just to give you a little example of the counties that they all touch, there are 27 counties that the 9 applicants that were approved will complete work in. So of the 64 counties in Colorado, we're into 27 of them with this grant, which was really exciting. Some of the grantees presented advantageous project plans. A lot of them were around expanding mobile services, specifically in our rural areas and our mountain towns, and outfitting some mobile vehicles to reach individuals who are in a crisis and need support. Also converting property into temporary housing facilities, because we know that housing is a big part of their stability and ensuring that they're able to access the resources they need. And there's a focus on underserved populations. So we're in some of the counties like Bent, Crowley, Route, Summit. So we're really into some areas where we can reach individuals who may not have access to these services normally. So it's a really quick presentation, like I said, and I speak fast. So does anyone have any questions or want me to go over anything?
Thank you so much, Jay. That was really helpful. And we're excited to hear more as these projects sort of move forward, and likely we'll have you or some of these grantees back to share some updates. So thank you for providing the overview. We're really excited about these grants starting to roll out and funding getting out into the community.
Yes, we are too. Thank you for letting me provide the overview.
All right. So a little bit more about our grant programs. Next slide, please. I'll move on to talking a bit about our open grant opportunities. Next slide. So just to give you a high-level overview of our grants and where we are in the process of rolling these out. So we have had 7 grant initiatives that have opened their requests for application, or RFAs, and since closed. Across those 7 grant initiatives, we have selected 53 grantees, which is so exciting, again, to start to see grantees be selected and these contracts, grant agreements be signed, and the work starting to begin. You can see that grantees really run the spectrum. We've got HCBS and behavioral health providers. We have training providers, case management agencies, and community-based organizations that are the recipients of these funds. In total, thus far, we have awarded approximately $30 million out to these organizations. In addition to that, we have currently have 2 grant opportunities open. One of those is actually sort of a 2-part grant. There's a provider opportunity, and then there's an opportunity for some individuals to apply. That's our training fund, and that is rolling. So it's open right now and will stay open. And then we have one other grant that has since closed, but we are currently reviewing applications. The Digital Transformation Project received over 200 applications, which is amazing. And so there's, as you can imagine, a huge effort underway to get those applications reviewed and the grantees named. So that will be coming very shortly. So next slide. So we're going to go into a little more detail about those open requests for application, as we would love to see more applicants and really encourage people to apply. So for the training fund, I'd like to invite Heather Johnson to come on and talk a little bit about those. She is our long-term care direct care workforce supervisor, and there's a lot of great opportunities around training here.
Thank you, Haley. As Haley said, we do have 2 grants open through this fund. The real big purpose of this training fund is to provide additional training opportunities for the direct care workforce. That's wide open, right? Like, what does that really look like? And so we really want folks to be creative. We've had 2 grant cycles so far, and we've had the opportunity to see a lot of wonderful applications. Some really met the intentions of the grant and some didn't. So What we're really looking for is training that offers specialization that better supports the HCBS population and the HCBS workforce, and training that supports advancement opportunities for the direct care workforce. So if you want to go to the next slide, I'll break out these two grant opportunities. So the training fund for the providers, it is open to HCBS providers and training agencies to create that training or deliver that training to an HCBS provider. There are, I believe, 4 more grant cycles left, and it's up to $100,000. So we'll consider grants of any size up to $100,000. If you are thinking something small and saying, hey, like, let's look at $10,000 and do this thing and see how it works, then maybe we can replicate it. We'd love to entertain that. The application process is online. You fill out the application, you upload some of the documents. One of those is the budget worksheet. We do have a lot of supplemental materials online. We've recorded informational webinars, so that's there for your at your leisure to go through and watch. We do have another one coming up. I believe if you check out the stakeholder calendar, you'll see the invite, but it is on the 21st at 12:30. So you can come and listen to us do an overview of the training, and then that's a great time for you to have ask questions and kind of get an idea there. And we just opened the grant cycle on February 1st, so it'll be open for 2 months. You can also email us with questions you have. We really don't provide individual responses to email questions. What we do is we gather them all and we put them on the FAQ so everyone has access to that information. So when you were thinking of these kind of grants, think about things that will support your workforce that aren't already required. And that's something that a lot of folks get hung up on. Is we understand there's the need to provide that direct onboarding and annual training, but this grant cannot cover that. It has to be for training that is outside of that initial ongoing training. So if you want to go to the next slide, I will talk about the individual grant. This just opened on the 10th of February. These are $500 grants for direct care workers for, again, any kind of training that is outside of their initial onboarding or ongoing training that would be required. We've had some folks interested in like, hey, I'm doing this, but if I take it to the next level, you know, that will help me leverage more jobs or, you know, work with more members. So we're really kind of looking for that. Those kind of trainings. We will have an FAQ coming up for that to provide just maybe some ideas of where to go for these trainings. I think it is important for folks to know that these grants are reimbursement based. And so you kind of want to think through that and what can be funded and then, you know, be eligible for those reimbursements. So we will likely record kind of an informational webinar for the individual grant and post it. We understand that the traditional timeframes of 8 to 5 are not really when direct care workers are available to come to attend a session. So we're looking for some opportunities to reach them and then also to be able to provide some information for them in a manner that they can access when it is convenient for them. And I think that is it. I will again extend the invitation to come next Tuesday, 12:30 to 1:30 for our informational webinar for the provider grant. If you want to ask questions about the individual grant, we can answer them there as well.
Thank you so much, Heather. And we did put the links in the chat where you can find out more information about this grant opportunity, as well as all of the others that are open or coming soon. And we also linked to the stakeholder engagement calendar, which is going to list all of our upcoming opportunities, like Heather mentioned, where you can come and learn more about the grants or participate in some of our ARPA projects. So I encourage you to take a look at those pages. They are great resources. So we will have an opportunity for questions in just a couple slides. So Heather, don't go far. But next up, I'd like to ask Roderick Prayer to join us. He is the Strategic Outcomes Division Director within our newer office, the Behavioral Health Initiatives and Coverage Office, or BIC, and he's going to talk about two grant opportunities. This first one is 3.07 Wraparound Services Peer Support Grants for Housing Stability. This one is currently open. And then he'll also share a little bit about a grant that's not yet available, but will be coming this spring and is actually outside of our ARPA HCBS funding. But it is ARPA funded through a different source, the State and Local Fiscal Recovery Fund. So we thought this would be a good opportunity to share about that upcoming grant opportunity. So Roderick, are you on?
I'm on, thank you.
Great.
Awesome, thanks Haley, and welcome everyone. Like Haley said, my name is Roger Pereira and I am the Strategic Outcome Division Director. And today I will be talking about the 3.07 Wraparound Services Support Grants for Housing Stability. And the summary of this project, the purpose of this project is to expand access to peer support services to Medicaid members that present with complex needs and history of homelessness. This project is funded, may be awarded to cover costs associated with outreach, engagement, hiring, training, retention, and supervision of peer support. Professionals that can provide billable service in this context of housing stability funding may be also awarded to support costs associated with building administrative capacity, to become a medical provider, a Medicaid provider, excuse me, and successfully provide and bill for peer support services. This grant is a total award of over $2 million, and the maximum award amount is $180,000. Next slide, please. And so for this, RFA is now open and attaches the link to apply for this grant. Who is eligible for this grant? Medicaid providers working with unhoused population, newly transitioned or Medicaid members receiving housing supports, housing and homelessness service providers who plan to enroll with Medicaid during the grant period and provide billable service support services. Review for requests for application. For more detail on the grant eligibility application requirements, you can email your questions to hickcliffhousingsupport@state.co.us. And Amy Austin is the lead on this project. Previously, she had 2 webinars set up. She did notify me that she also have a third one set up. So you're looking at February 17th, 2023 from 12 to 1, March 3rd from 12 to 1, and March 15th, which is our new webinar session from 4 to 5 p.m. The deadline for this application is March 31st at 5 p.m. Mountain Time. Next slide, please. All right, so this is the grant that Hay was referring to earlier. This is a grant that we're currently working on. This grant was created through House Bill 22-1302, and it was created to develop infrastructure for primary care, pediatric, and behavioral health professions to better serve individuals with behavioral health needs in outpatient and healthcare settings. Also looking to increase access to quality health care for individuals that present with behavioral health needs. This will also hopefully help expand early interventions tactics that reduce escalation of behavioral health conditions. So with that said, this is funded through ARPA state and local fiscal recovery funds, SLRF, and it's a little over $29 million available for grant funding. The maximum award of this grant is $400,000, with the estimated average award will be $200,000. Anyone that's a larger grant will only be available for necessary for larger practices that can demonstrate potential broad impact, and definitely speaking about sustainability. Award amounts will depend on the scope of Medicaid members served through allowable services and the number of quality of applicants. We are anticipating on these up to 150 sites, with up to 5 sites allowed per application. We have already we already selected our steering committee folks, which we had a kickoff meeting last Friday. So excited about that. We did share our RFA for comment. It is open for comment right now on our website, which is also the next page. And so just kind of go through our project timeline. So RFA open for comment would be closed. We're in that on February 20th, or probably end of February. Probably extend that a little bit because we have gotten a lot of feedback. We have also hosted 2 webinars on the 15th and 16th, and 14th and 15th. And so those are also posted too. So you can listen to those webinars if you have any questions. We are also looking to release the RFA on March 22nd through April 26th. And then in June, we will announce the award amount. And then we will grant that award starting June 1st through December 2026. Next slide. I think that was it.
Great. Thank you so much, Roderick. And thank you, Heather, for sharing about these grant opportunities. We really want to get the word out about these and encourage people to apply. So if you know of anyone that may be interested or might be a good fit, please encourage them to check out our website. We have added some links here. I know that we've put those in the chat as well. Just a couple of reminders, if you're interested in applying for a grant, please do check the Secretary of State website and just make sure that you're registered and in good standing. That's something that we're required to do. So it's best if you do it ahead of us so that we know it's taken care of. Keep an eye on our ARPA grant opportunity webpage. As we said, these 2 grants are open right now, but there are more coming. The one Roderick just spoke of, but there are others that will be opening in the spring and summer. So keep an eye on that website. Add that tab and favorite it so that you can visit it often to be sure that you know what's coming up. We also have our ARPA Project Pulse newsletter that goes out every month, and that always lists open grant opportunities or upcoming grant opportunities. So take a look at that when that comes in your inbox. And we always just like to remind people, I know that Heather spoke about this briefly, but these funds are required to supplement your work, not supplant existing funds. So that means we really need to be investing and using these funds for new activities. They cannot be used for efforts that are already underway. So just a reminder there when you're thinking about those applications and what might be allowable, that's a good thing to keep in mind. Next slide. So since we did talk quite a bit about these open grant opportunities, we wanted to give a chance for people to ask any questions, anything that may have come to mind when Heather or Roderick were sharing about their grants. I will pause and see if anybody would like to unmute. You can press *6 if you're on your phone, or you can raise your hand if you are on your computer. I will pause for 1 minute. See. All right, not hearing any questions or seeing any hands raised. I'll keep us moving. Next slide, please. All right, so we always reserve a little bit of time during these ARPA HCBS presentations and webinars in the event that there are important, timely updates that from other parts of the department that we'd like to include. And so we'll move into that and provide a couple of things for all of you that we thought were important to get in front of you right now. Next slide. So first, we wanted to share a couple of opportunities to complete some surveys that are live. Again, we really want to get the word out about opportunities like these and appreciate you participating, but also sharing these with others. So if you have a chance to share these with your network, that would be really appreciated. This equity study survey is live right now, but closes tomorrow. So really would love people to jump on this opportunity to complete the survey. We're really trying to better understand disparities across HCBS. So this survey is just one component of this project, but we are seeking input from a wide variety of stakeholders to understand more about members and providers' experience pertaining to awareness and outreach, enrollment, and use of HCBS. This survey would take approximately 10 minutes to complete, so not a huge lift, and we do have it available in Spanish as well, and we'll add those links in the chat. Next slide, please. One more survey to plug before we move along. our member tech literacy survey. So we have partnered with the Center for Inclusive Design and Engineering at the University of Colorado, Denver, to develop a digital literacy training curriculum, and we hope to pilot this program. We are conducting this initial survey with families, members, providers, advocates, to better understand the gaps in digital literacy of Medicaid long-term services and supports members, and how these gaps may impact access to healthcare information and services. So this survey will really help inform the development of that new digital literacy training. So it's critical that we hear from a wide variety of stakeholders to understand what the challenges are, so that that curriculum can really be best designed to meet the needs. So if you can please, again, take this survey. You have a little more time, March 1st, 2023 for this one, and also share it out with your network so that we can really get a lot of feedback as we are working to develop this new tech literacy training. Next slide, please. All right, now I'll move us on to a couple of other updates. Next slide. All right, I'm going to ask Amanda Lofgren to come back on and share a couple of important updates around our case management redesign effort.
Great, thank you, Haley. Again, my name is Amanda Lofgren. I'm the Case Management and Quality Performance Division Director, and just wanted to provide an update around case management redesign. The department is working on implementing House Bill 211187, which requires the department to come into compliance with conflict-free case management, while also improving quality, increasing accountability, transparency, streamlining, and simplifying the way that our current case management system works. Really, at the end of the day, to improve access for individual members and their families. So we currently have open a competitive request for proposal seeking case management agencies that will serve 20 catchment areas. This RFP is open through February 28th and will close at that time. We plan to initiate notice of intent to awards for those case management agencies that are selected in May or June, and we will begin transitioning. We'll have 3 cohorts. The first cohort will start in August of this year with the transitions in November. We will have a second transition in April of next calendar year, with the final transition being June of 2024. This is our goal, to minimize impact to member and disruption across the system while we go from 44 case management agencies to 20 serving our members statewide. We, during this RFP period, did put a hold on one of our ARPA projects that was intended to provide capacity building support to our current case management agencies as they begin to prepare for transitions, and really work on organizational readiness and supporting our case managers across the state through learning collaboratives. This work will resume again in March after the RFP closes. Another piece that we are working on is we will be coordinating and collaborating with our Community First Choice Council, and at their April 5th meeting, we'll be speaking about case management redesign as it relates to the interconnections to Community First Choices. We'll particularly be focusing on children's waivers and making sure that we come into compliance with conflict-free case management. So thank you, Haley, and I will turn it back over to you for settings rule.
Great, thanks, Amanda. Well, it's pretty hard to believe that we are announcing the upcoming end of the settings rule. You can go to the next slide, thank you. So for those of you that have been around, you know well about the HCBS final settings rule. It was a federal rule that was issued back in 2014 that set criteria for settings where people live or receive HCBS, and was really meant to better differentiate institutional settings and HCBS settings. It named and defined basic rights, including privacy, dignity, respect, freedom from coercion and restraint, community integration, and much more than that. Had additional rights requirements around visitors, food, and things such as that. And it outlined a process for individualized rights modification. The transition period, which has been underway for many years, is ending March 17th, 2023. So in just about a month away. The CMS did allow for states to request for a corrective action plan. You can see ours. We did submit that by the deadline last year. And it does provide additional time for a very small subset of settings who had remaining compliance issues related to integration. So really, CMS really understood that the public health emergency, the pandemic has put a major constraint on providers' ability to hire and integrate individuals into the community. And so they allowed for a corrective action plan from states to give a little bit of more time for those providers that have not been able to come into compliance in very particular areas. And so we did apply, as I said, and have allowed for that extra time for a very small subset of providers. Next slide, please. So just to give you a little bit more information about where we are in terms of coming into compliance, we codified the federal rule on January 10th, 2022. We have had critical waiver and rule updates go into effect, and we're working still through a couple of more. We have a couple of non-critical updates that are underway as part of case management redesign. And we did want to plug that CMS, they've been going out to states and doing some site reviews, site visits, and they produced a report on their findings, which we looked very closely at, and just to understand what CMS was finding and learning from other states. And we feel really confident in our interpretation of the rule from their findings, as some of the issues that they identified in other states are things that we stood pretty firm on, and feel like we've gone the right path in terms of making sure our providers are in compliance with that federal rule. I'm excited to say that 97% of our settings that were part of the transition period have been verified as compliant, which is really just an incredible feat, and want to thank all of our providers and our the associations who have been partners in getting the word out about this to make sure that we could get those providers into compliance in time. There are 81 settings that are not yet in compliance. 55 of those settings are getting extra time under our cap. So because they had a challenge related to the PHE, they are being given some extra time. 26 providers are not getting extra time. Their non-compliance issues are not related to the PHE, and so they are required to come into compliance by that March 17th deadline. 8 of those settings are residential and 18 are non-residential. We have been working diligently with CDPH&E over the last couple of months, and will continue to work with them over this last month to try to give them all of the extra technical assistance that they may need and support that they may need to get them to compliance. But we are also simultaneously working with case management agencies to support transitions as they are needed. So if these settings are unable to come into compliance, we want to ensure that our members are moved to another provider so that their care is not impacted. So we wanted to make sure you had this update, since I believe our next webinar is actually March 16th, the day before the settings rule transition period ends. So wanted to highlight where we are, send out a thank you to everybody for your partnership over many years to get our providers into compliance, and also give you just a little bit of a heads up about that we still do have, you know, a handful of providers that are not in compliance that we are working very hard to help support and get there. All right, next slide, please. All right, I would like to welcome Mark Williams, who is our Public Information Officer, who has joined us to provide a little bit of information about the COVID-19 public health emergency. As many of you know, there's been lots of announcements recently, and we wanted to be sure that you heard from us how that's impacting our members and our providers. So Mark, can I invite you to speak next?
You may do so. Thank you, Haley. Good afternoon, everyone. I'm going to just give you kind of a 10,000-foot view over, pardon me, over the work that's been going on and what's happening with this. So when the public health emergency first began, it precluded states from disenrolling members who were already enrolled, because obviously you don't want to be disenrolling members from Medicaid or CHIP in the midst of a pandemic. So since the outset, that continuous coverage provision, if you will, has been linked to the public health emergency. Then in December, when Congress passed and the president signed the budget bill, that bill included a provision to end the medical assistance continuous coverage requirement effective this spring. So, pardon me. When they did that, it decoupled the continuous coverage requirement from the public health emergency, and it required states to return to our normal pre-pandemic eligibility review process. And states had the option of doing that either in April, May, or June, so that we had some flexibility. Colorado has chosen to start that process of reviewing eligibility, or redeterminations as we refer to it, in May, but I'll get to that a little more in a moment. So in January, President Biden announced the end of the PHE will happen on May 11th. And so during the public health emergency, there were a number of emergency policies put in place, and by ending the public health emergency, we have to go through the process of either discontinuing some of those policies that were put into place, and they were primarily done so to ease restrictions, if you will, or if we decide not to continue with those policies, we need to make them permanent. I'm sorry, I misspoke there. So either you can discontinue some of those emergency policies, or you can make them permanent. Colorado did so, for instance, with telehealth, making that an ongoing policy. Next slide, please. So it's important to know that not all of our 1.7 Health First Colorado members and our CHIP members will be reviewed or renewed at the same time. Colorado will spread this out over the next 12 months, 14 months if you include the advance notice that we'll provide. And that noticing period, or those redeterminations rather, those will align with the month that the member enrolled in the Medicaid program. So if you enrolled in Medicaid or CHIP in July in a previous year, you will be renewed or redetermined this coming July. So in this case, though, Colorado, you'll recall on the previous slide, I mentioned that the feds gave us the flexibility to begin this in April, May, or June. Colorado has chosen to do this in May, kind of in the middle of that window, if you will. And we will begin sending those renewal notices to those people with a May eligibility. Those notices will start going out in mid-March, so that people will have plenty of time to understand what they need to do and fill out the information, and then get that back to me. Next slide, please. All right, so we have created a number of partner resources to help our partners communicate what is happening. And in particular, we have created 3 toolkits that we have shared with partners and stakeholders. to help them spread the word and help members understand what's coming. These toolkits provide collateral and messaging for those partners to use. The first one we did was the, sorry about that, trying to get my place here. The first one we did was update your address, which is pretty straightforward in just that. Obviously, we need to know how to reach and where to reach members so that we can get the information to them when their renewal period comes up. However, the fastest and easiest way to do this is through our PEAK website at co.gov/PEAK, P-E-A-K, or downloading the PEAK app from the Apple or Google Play stores. That, like I said, is the easiest way to go about it. The second toolkit that we published was the Preparing for Renewals toolkit. It provides guidance to help in understanding the renewal process and reviews the following key terms: automatic renewal process, or ex parte, as we sometimes refer to it, along with other coverage options and sample member correspondence. So that again would be for our partners to help get that information out. The toolkit also includes links and how-to guides for some of those key tasks. Lastly, the Take Action toolkit. The materials in this toolkit are designed to encourage members to look for their renewal paperwork in the mail and the PEAK mailbox and take action when they get them. This is important because members must complete, sign, and return their renewal packet to keep their health coverage if they still qualify, or they can also do that through the PEAK site. But one of the largest reasons why somebody might lose coverage, historically speaking, is that they fail to return the information in a timely manner or they forget to sign it. So in this case, those details matter. Next slide, please. All right, so what can you do to help us? There are a few things. If you would like to learn more and get a little deeper into the weeds in this, we have a April 26th webinar scheduled where people can come in and learn more information about where we're at and what to expect. The other piece that I skipped over here earlier, if there is one thing to take away from this brief presentation, it is that link that talks about the COVID-19 PHE planning. It's the link in the first bullet on this slide. And we can drop that into the chat as well. But this PHE planning webpage is pretty much a one-stop shop for anything that a member and or a partner, a stakeholder would need to be able to communicate with the members. So again, going back to that webinar, we encourage you to participate in that if you're able. We also have these toolkits loaded on our PHE planning page, and we will drop those into the chat as well. But you can go back and take a look at it. And like I said, those toolkits contain all sorts of resources, things like social media posts, email language, on hold messages for call centers or IVRs. So there are some real good resources in there that can be available to you. And then lastly, for the next slide, please, if you have any questions or need further information, please contact my colleague Allison Ludden or myself. Our emails are there, and we look forward to answering any questions you may have.
Thank you so much, Mark, for that overview. If you can go to the next slide. We will pause and see if there are any questions. I know this section was a lot of information. Amanda talked about case management redesign. I gave some updates around the settings rule, and then Mark provided some information about the PHE. Anyone have questions about any of those topics or other topics that you would like to pose right now? All right, not seeing any. I will move us along. We did post the link to this PowerPoint in the chat, and we will do so again so that you have it. I know there are so many links that were shared in the chat today, and so it can be hard to keep up. But if you go to where this PowerPoint is posted on our website, you should be able to access all of those links there. We will ask that you complete our 60-second satisfaction survey. We try to keep it short and sweet, but it is really helpful for us to know and get that feedback from you about how helpful this webinar was. We're always looking to improve and make sure that we are tailoring it to provide information about what you're interested in. So if you can click on this link and just take 60 seconds when we close to complete the survey, that would be really helpful for us. Next slide, please. We wanted to put a plug for our next webinars. We have posted our webinars for the entire year, so you can get those on your calendar. As similar to last year, we are sort of going back and forth between ARPA webinars and then OCL, more generic, broad webinars. So next month will be our OCL webinars. We will have 2 opportunities, as we have done in the past. You can see here we have one that's tailored to our disability community in the morning on March 16th. And then we have a second opportunity for our providers in the afternoon of the 16th from 3 to 4. So we do encourage you to participate in these webinars. They happen about every month, and they are really helpful to be able for us to be able to share with you, and also for you to share with us. We love to gather feedback and hear from all of you through these webinars. So please add those to your calendar. We did put a link in the chat to our website where you can see all of the upcoming webinars, and be sure to get those on your calendar. Next slide. All right, and that is the conclusion of our webinar. I want to thank all of our guest speakers today. They shared some incredible information about some really exciting ARPA initiatives, and also just some upcoming grant opportunities and other really important department-wide updates. So thank you so much for joining us, and we look forward to seeing you next month on March 16th for our next 2 webinars, and we will see you then. Thank you.